heart failure with reduced ejection fraction, the ACE inhibitors and patient are already on ACE inhibitors in ARNI. The patient should be shifted to ARNI. So the most important point that comes to us would be the cost only. Uh, the stable chronic heart failures, they have an illusion of stability. Most of the trials have shown that these patients under the follow-up, they have multiple hospitalization, and many of these patients, they die suddenly. So these heart failure patients, they are not actually stable. It was thought these patients are stable, but they are never stable. They have certain deteriorations, they have certain hospitalizations, and many of these events, they are not predicted. So it is better to shift these patients from ACE inhibitors and ARBs to immediately to ARNI. The only probable reason why one should constrain upon shifting these patients to ARNI should be the cost. If the patient is not able to afford these drugs, then that would be the only possible reason why these patients should not be shifted to ARNI. Or if the patient has some angioedema or renal or hypertension related side effects to ARNI. So so as per the guidelines also, it is a class 1A indication that the patients who are in NOHA class 2, 3, these patients should be shifted to ARNI to reduce the mortality. And these patients who present with these heart failure patients who in the use, it is important that to use ACE inhibitors only in the patients where ARNI is not feasible. These patients where there are intolerable side effects, that is probably the only reason why it should not be given. So next is acute decompensated heart failure different from de novo heart failure? Uh, the thing is that this acute decompensated heart failure has maybe a different phenotype, or maybe a continuation of a single disease only. Though these patients, they will have a past history of heart failure, the comorbidities in patients who have a de novo, they were found to be less. The trigger events are slightly different. The clinical presentation would be a more severe type of a pulmonary edema and cardiogenic shock, because these patients, they are not previously put on any treatment. So these patients, they are slightly different from the patients who are already having a decompensated chronic heart failure. The chronic heart failure patients would have more comorbidities. They will accumulate over a period of time. These patients would not present with such a severe type of heart failure at the time of presentation, because they are already on these kind of disease, but they will have more comorbidities.